Uh, my name's Richard Vines. I'm a director and co-founder of Rare Cancers Australia, and Kate lets me call myself chief executive, but we all really know the truth, so it's okay. My job today is to talk about the report, but before I do that, I want to acknowledge some people in the room. Firstly, Plum Stone, who actually wrote this report and probably should give this presentation, but she's very kindly let me do it. Nash Chance, who's over there, who did all the hard yards. He's doing pure maths and commerce at university and spent most of his summer delving into statistics and AIHW data and knows more about Excel and God knows what than I care to think about, and Eliza Mitchell, who also did an enormous amount of work around research, particularly around some of the PBS data that we produced. Thanks to all of the MPs and senators in the room. Particularly I'd like to acknowledge Mel Brough, whom we've worked with over a couple of years and sadly has decided to go off and retire from this house, and I just want to say thank you to Mel, and also to let him know that that after he's had his R&R, we'll probably be knocking on his door and seeing if we can get him to help. But he's been brilliant for Rare Cancers. A big thanks to the patients and carers that are in the room, and a big thanks also to our report sponsors. I should have a slide which nominates who you all are, but you're all printed in glorious detail in the inside couple of pages of the report, and thank you to all of you. A lot of those sponsors from the pharmaceutical industry, and I was at a function last week where someone from government suggested that patient groups that worked with pharmaceutical companies were somehow tainted, and I'd just like to put on the record that that's complete rubbish and offensive. The irony of it is that any financial support provided by a pharmaceutical company to a patient group, ours or any others, is minuscule compared to what a pharmaceutical company needs to provide to government to even get drugs assessed. And if they're not corrupted, then we're not. Okay, just wanted to get that off my chest. Our job is about highlighting patient needs. It's not about recommending drugs, it's about saying, hey, there are people out there in need and you should consider what you can do to try and help it. And it's also about giving patients a voice, which is why when you read this report, you'll find that there's a lot of patient stories in there. And I just want to make the point that there's a lot of health economists and there are clinicians in this room, and there are other experts, but the guy who knows most about brentuximab is Angus. He's the patient expert. And the person who knows second most about it is Tricia. And we know nothing by comparison. And we need to respect that, and we need to listen to them. So let's talk about our report. Pretty much our logo, our Rare Cancers logo, says it all in terms of this report. It is... I had breakfast with a geneticist recently, and we thought our logo meant that it was designed to represent that rare cancers impact the whole community. And this geneticist also said, yeah, but it also represents broken DNA strands and mutations that attach to them. So I figure if you put those two concepts together, then what you have is a logo that represents that there are genetic mutations and mechanisms that are causing cancers through the community, and that's really what we're trying to say. And we're really trying to say that what you need to do is get focused and active in trying to solve that. Of all of the slides that I'll show you today, this one is the most powerful in that the graph on the left is for common cancers, and what you see is a very dramatic increase in diagnosis or incidence and a corresponding decrease in mortality. What you see for rare cancers is pretty much the reverse. Rare cancer mortality just continues to climb disproportionately to population growth. Part of that is due to demographic factors. Part of it is due to the fact that we're not doing enough. A patient today diagnosed with a rare cancer is almost twice as likely to die as a patient with a common cancer. that is just outrageous, and it can't be allowed to continue. I'm going to talk a little bit about the burden of disease as it extends through the community. You know, we think of cancer as something that impacts the elderly, like heart disease or dementia or arthritis. And I can speak personally from arthritis. But cancer is not a disease of the elderly, it's a disease of the community. We have people like Angus and Matt here today, and Eric, you know, who span generations, but are all fighting and struggling with the same nature of disease. And if we look at the next slide, we see that rare and less common cancers are claiming 1 child every 4 days, 1 Gen Y every day, 10 Gen X's every day. And in baby boomers, the impact is so great. It's just more than coronary heart disease and lung cancer combined. And we need to stop pretending that these are 200 separate diseases. They have commonalities, they are treatable, and we need to get busy. And I'll just quickly run through some of the comparisons here. I won't stay on these slides too long. But for child cancers, it is, 95% of all cancer deaths in children are caused by rare and less common cancers. And it's the most common cause of death for children under 15. It's more common than, more children die than with traffic accidents, accidental drowning, accidental poisonings. It's astonishing figures. Gen Y, very similar. We have suicide as the highest killer, and then we get into traffic incidents, and then we find that rare and less common cancers account for 61% of all cancer deaths in this age group. Gen Y, 40, in our case, we've done this as 40 to 59-year-olds, and I apologise to the 59-year-olds who might have thought they were baby boomers, but it's the only way we could get comparative data in this, and it is the most common cause of death. So again, we see this coming at you all the time, that the impact across the community is immense. Baby boomers, it just goes off the scale, and beyond baby boomers, it gets worse. So we've started this conversation 2 or 3 years ago when we said that rare and less common cancers account for over 50% of all cancer deaths across the spectrum, and that is very much the case with baby boomers, but it also works at every level of the community. And part of our problem with this, and part of our struggle, is that we are doing, if we look at research funding and you look at what's actually happened and what's gone out according to the Cancer Australia audit of that, it's less than 2% of funding available is going to rare cancers, and around 19% going to less common. And the implications of that are not only in terms of treatments and cures, but they directly come to the fore in terms of clinical expertise. If you don't have researchers working on these cancers, you don't build up knowledge, and you don't build up clinical expertise, and you don't build up centres of excellence. We need to have, and the only way we're going to do this is by some form of affirmative action from government. Last time we looked at the dollar value of treatment through the PBS, and this time we thought, well, we need to look at what's happened. So we went back over the last 6 years and looked at all of the treatment approvals since 2010, and there have been 85 for treatments of all cancers, of new drugs being approved, of which 4 of those fit the category of rare cancers. I think anyone would suggest that that's disproportionate. And part of the problem with this, and it is an issue, is if you talk to people inside the PBAC, they will say, we can't assess a drug if industry doesn't apply. But we have a system whereby there's no incentive for industry to apply. It's not a commercially viable business. We have a natural disconnect between private enterprise global companies who are sitting there trying to make commercial decisions about what they're likely to get up for funding. And we have a government body sitting there saying, with a set of rules that make it almost impossible to get those up. And it's not good enough to say, well, we just have a standoff. Both sides need to come together and find a way to get these drugs on the system. And that is particularly relevant for drugs that are already listed for common cancers. If you've got, we run a crowdfunding model, which we've used with Angus and others with great success. And in the last 6 months, in the last 4 months, we've had 10 different oncologists prescribe the same medication for 10 different patients for 10 different cancers. So oncologists think this drug works for 10 different indications and have gone to the level of referring patients to us for crowdfunding to try to be able to afford it. And yet that drug, if any of those patients had melanomas, they would be paying $37 a month for that treatment, and with us they've got to pay $9,000 to $10,000. Because they've got rare cancers, they've got to pay $9,000 to $10,000. So we have a consensus among the clinical community that the drug works, but we have no mechanism to get it listed for these cancers, and that pretty much describes the problem. We've got treatments available that we can't get listed and funded for rare cancer patients. And if you're unfortunate enough to be diagnosed with a rare cancer, you are immediately in a minority and you are immediately discriminated against, and the community abandons you. And that's what we need to address. And it's simple to address because the drugs are in country, they've been through TGA approval, they're sitting there, they're waiting. All we need to do is say, hey, you can not only use it for melanoma or breast cancer, you can also use it for these other indications. It can't be that hard. It can't be, if my simple mind can get my head around the possibilities, then it can't be that difficult for everybody else to do it. We've already agreed a price between government and manufacturer. How hard can it be? So there it is, four cancer treatments out of 85 for solid tumours. So I've kind of ranted on about this already, but what we need is directed research so that researchers can apply for funding for rare cancers, into rare cancers with some prospect of success, and that we make it more attractive for them to do that than to continue down the path of researching common cancers, which are already over 90% survival. We need support for health professionals to improve diagnosis. You can see the impact in common cancers where we've got screening programs, education programs, and early diagnosis. The impact is dramatic, and we can do that with rare cancers as well. And we need equitable access to treatment for all cancers, for all members of the community. You know, if you're in the community and you work hard and you contribute and you pay your taxes, the nature of the disease should not define the care that the community offers you. Rare cancers are a challenge, and we can meet it, and we can do better, and we must do better, and we can give these people a little more time. Thank you. I'll take some questions. If there's any questions, we don't have a roving microphone, so I'll try and repeat it as you say it. Far away.
Richard, Adrian Dolhandy from Bayer. This is an updated report that you're launching today. The original one was launched 2 years ago.
Yep.
It seems to me that Rare Cancers Australia's momentum is unstoppable now. What do you see has been the greatest strides that have occurred in this space since the launch of the original report?
I think the most heartening thing that's come to me has been walking down the halls of this place and having the Health Minister's senior advisor on the PBS, and we have version 2.0 of that advisor standing in the doorway in Alex Best, but they both said to me, we know we have a problem with rare. And I think that's what you need. That's what we didn't have 2 years ago. We didn't have an acknowledgement that there was an issue to be addressed. And I'm really confident. This is not a problem, and I've said this several times, this is not a problem created by this government. It's just that this government has an opportunity to fix it. Yes, sir. Sorry.
Susan Pitt from Friendship Alliance, but I'm representing Cancer Voices today. Richard, do you have any views on equitable access to cancer nurses?
Yes, I do, and it's we need them. Kate looks after all our patients through Rare Cancers Australia, and she does an amazing job of talking and liaising, and we are trying to get to a point where we can fund nurses because the journey, in some respects, you know, there's as we all know, the McGrath Foundation does a fantastic job in providing breast cancer nurses. But for rare cancer patients, navigating the health system is infinitely more complex because there's less infrastructure in place, there's less centres of excellence, and the need for nurses in and around rare cancers or less common cancers like brain tumours and have you is just extreme because there's so little coherence in the way that we deal with them, and knowing the first question that we get pretty much from every patient, I think Kate would, is like, I've just been diagnosed with this, where can I go for someone who knows something about it? Because my oncologist is told I'm the first one he's ever seen. And so we need lots of support, lots of nurses, and we will get there. We just have to find a way to fund them.